four great presentations today. The first thing I'd like to do is welcome Dr. Stephen Chevalier, who's a member of the committee. He's sitting right here to my right. He's appointed, and he has with the Children's Medical Clinic. He's had some conflicts on Thursdays. He and Dr. Jay Underwood, who has been here, is sharing duty. We want to thank you for being with us today. I'd like to first turn it over for our first presentation from Dr. Daniel Eddy to Dr. Jennifer Bryan to introduce him.
Thank you, Mr. Chair, and welcome everyone. I have the pleasure of introducing our first speaker. You all know him as our State Health Officer, Dr. Daniel Edney, who practiced internal medicine for many years in Vicksburg and also has and continues to service with his history in addictionology. A longtime server of patients, the public, and physicians in organized medicine circles, and most recently elected president-elect, hot off the presses for, you're going to say the name of this, but it's ASHO, which is the American Association of Territorial and State Health Officers. I got it wrong, but it's all of the state health officers in the country. He's the president-elect. So we are very proud of his leadership. And thank you for being here, Dr. Edney. Correct me on the full title, though, and thank you again. We look forward to hearing from you.
Great. Thank you, Dr. Bryan. Thank you, Mr. Chair and committee members. I always appreciate the opportunity to come visit at the Capitol and share what we are learning at your State Department of Health. And very happy to do so in compliance with State Code 41-3-15, which is our powers and duties section for your State Board of Health and the State Health Officer. And I bring that up because you actually task us with studying things that you're studying right now. And so even though the health department has no jurisdiction over health insurance, and Commissioner Cheney, I'd rather keep it that way, that we still are charged with studying the health of the population and the things that impact the health of the population of Mississippi. And in fact, very recently, you added a responsibility to us to study comprehensively health and health care throughout the state, and the conversations that you're having factor into that. So we have been looking at these things. I'm going to just share with you briefly a few things that we're seeing for your consideration. But I like to set the stage to remind you, as our elected officials and subject matter experts, why I hope you're having this conversation. It's not about insurance companies. It's not about products. It is about our people and the health of our people. And at the Department of Health, we studied, as part of our study of the health of the population, we went back to 1950, which is a reasonable life expectancy for a Mississippian. And we looked at the excess mortality year by year from 1950 through 2024 and compared it to the mortality rate that's an average for the country. And every year we added the number of deaths in Mississippi that are higher than the U.S. mortality rate and added all of those years up. And it's important for you to know that that number was about 280,000 people who are not alive today, who, if we were just average in health, if we scored in health outcomes at an average rate with the rest of the country, not a superstar state, but just average, there would be 280,000 people alive today who are not alive. These are not potential, these are actual. And that didn't factor in the fact of babies dying unnecessarily who did not have a chance to reproduce, not factoring in children dying, young people dying of accidents. And when you factor that number in and you adjust for that, then we're well above 300,000 Mississippians who are not alive today who would be alive otherwise. They may not be living in Mississippi, but they'd be living somewhere. So I share that with you to try to ask you to think of this. You know, that is another congressional district for our state. The population of Mississippi is artificially low because our health outcomes are so poor. And if we're worried about the population numbers, then these are things that we all have to work on together. And you're looking at one of the challenges that impacts the health of the state. You do need to know that the birth rate of Mississippi is declining. We're down about 1,000 live births per year, year over year, the last few years. 2023 was our first year where the number of deaths exceeded the number of live births. So the line has officially crossed and the birth trend is going down. So we need to really focus on the health of the state. And I keep challenging you, please look at the health of the population the same way you have been looking at education of the population. And if we can improve health the way that all together have improved education, you're going to impact poverty. And I think that's a certainty. So this is all about access to care, which is a very complicated issue. It's not insurance alone or the lack of it that impacts our access to care. It is impacted by education and not understanding the needs for health screenings and wellness checks. Clearly, poverty drives the bus and so many things in our state, and access to care is one of those things. Transportation is a huge challenge. If you have anything to do with anything in rural Mississippi at all, you know the transportation challenges of our lower income population, and that is very much true in health. And then it depends on what kind of job you work. My daddy was a truck driver. Truck drivers their schedules aren't conducive to going to the doctor and going for wellness checks. And men and women working 12-hour shifts. It's oftentimes difficult to get away, to access care, to have care for their children. There's so many things. But at the end of the day, insurance is our ticket to ride. Without insurance, nothing happens, or not much above free clinics or access to the ER, which is required by the federal government. So what you're studying is extremely important, and I'm so pleased that you are. And there are opportunities for us to do better than we're doing in terms of providing access to healthcare for our citizens. We are, and Commissioner Cheney is the expert here, but our coverage gap is much smaller now than it was 4 or 5 years ago. We've done a really nice job with enhanced subsidies with the federal marketplace plans of increase the number of Mississippians who have reasonable health insurance. We'll see what Congress does with those subsidies. Nobody knows, but I would suggest to you, you should assume that they're either going away or that they're going to be reduced, which means that coverage gap is likely to expand back some. I do think there are ways outside of Medicaid expansion, which to improve healthcare coverage for Mississippians outside of expanding Medicaid. And I'm in favor of whatever it takes to help lower income Mississippians, oftentimes who are working 2 and 3 jobs a day like my mother and father did, to have health insurance. And I can tell you as a physician, it is a game changer when an individual gets health insurance. When a low income worker who's not used to having insurance gets health insurance, it is revolutionary in their life. So in your county health departments, our public health clinics, we are charged to be part of the safety net. We serve a population that 40% of the people who come into our county health departments do not have insurance. Now, many of them are eligible. And so we now have a robust system where we determine their eligibility for Medicaid or for marketplace plans. And we're about to move into open enrollment period for marketplace. So we will be working as hard as we can as people come into the health department to determine their eligibility and get them enrolled. It is not an easy thing to do. If you've never helped someone apply for Medicaid or to apply for an ACA insurance product, it is not easy. And we do this at our free clinic in Vicksburg every month, and it takes somebody who knows how to navigate the system to help our patients enroll. We're doing that at the health department. But if we can narrow that 40% uninsured rate down to something more reasonable, like 15%, that funds public health in a much more robust way. So what are ways to do that? What are ways to close the insurance gap in the state? Well, one way that's available now, it was passed by Congress in 2019, went into effect in 2020, in the first Trump administration, and and we're not taking much advantage of it that I can see, but a lot more conversation is going on regarding ICHRA, which is Individual Coverage Health Reimbursement arrangements. And I think this is probably some of the low-hanging fruit that we need to be looking at. It would not require any state intervention. It's already there, but this would benefit more our small business owners. And when you look at employers who take advantage of ICHRA, the federal statute, to do this, it allows them to use pre-tax dollars to have health accounts for their employees. There's no floor, there's no ceiling. They can put whatever the lowest amount that they want to, and then that makes it available for their employees to use it for qualified healthcare expenses, including premiums for individual insurance plans. So an employer through ICHRA can provide funds for their employees that they're too small to be able to afford to have a true health insurance program for their company. They can't afford to have a group plan for their employees, but they can have a defined benefit where their employees can take that money and spend it through qualified means however they want to, but that would include spending it on their premiums for Affordable Care Act exchange policy. When you look at employers who take advantage of ICHRA, 83% of them nationally had never, ever provided any health benefits whatsoever. So especially for small employers, it makes a lot of sense to allow them to ease into providing health benefits for the employees. It's not just limited to small employers, it's any size employer, but it makes an awful lot of sense for the smaller employers to provide benefits for their employees. So they're not providing insurance, they're just providing funds that can be used in many ways. If you have a HSA or an FSA account with your insurance, you're used to what are qualified health expenses. The difference here is all those things would still apply, going to the doctor, test, x-rays, going to the ER, but being able to pay health insurance premiums is a big one. All right. Secondly, there's been a lot of conversation, and I know Commissioner Cheney has been working on this, and I think it's a really smart idea. Please don't tell Mike Cheney that I thought anything he was doing was a smart idea, but here's one, and that is using what is currently dormant with our state comprehensive health insurance risk pool. The high risk pool was really important before the Affordable Care Act, because we had too many Mississippians who had pre-existing conditions who could not get reasonably priced health care. And so the legislature formed a high-risk pool that the Insurance Commission was helping to administer. The Affordable Care Act really made it no longer necessary, made it moot because it eliminated pre-existing conditions and brought those premiums way down. But I'm not the expert, but as I understand it, it still exists. It's still a tool. And there's a lot of conversation about retooling it, however it would make sense with the commissioner's leadership, to provide another means for reasonable access to individual health insurance for Mississippians who just cannot afford it otherwise. So that, I didn't know how much y'all had talked about that opportunity, but that is a resource that is already there. I know that y'all, especially last session, we're talking about state exchanges for the Affordable Care Act, and that is, Commissioner Cheney is the expert there. As we study it, there are pluses and minuses with the state exchange. the downside is that the state has to pay to administer it. It's not cheap. There's a lot of volatility in that market. It may not be stable at a population our size, but the upswing is that when you look at states with state exchanges, the uptake with those are high, and that it's higher than states that don't have a state exchange. So there's increased uptake among the residents in those states of the exchange plans. The state is able to tailor them better. We're not able to tailor the federal exchange plans at all. We have no control over those, including we have very little control over the insurance companies that administer those plans versus a state exchange where the state has a lot more authority. But the big one, the one thing that makes no sense to me with the Affordable Care Act is why we have to have such a narrow open enrollment period for these low-income citizens who are needing individual health insurance. So when you're outside the open enrollment period, it is more difficult to access the federal exchanges. And to get a federal exchange policy, you can get one if you have a life change experience. But if you don't, you can't just slide in anytime you want to. Open enrollment will start next week, and we'll be enrolling as many people as we can. But with the state exchanges, the state can determine a more flexible enrollment period and more flexibility in allowing people to enroll. So there are pluses and minuses. But certainly, I think this task force needs to look at all of the options available. And then as a state health officer, I mean, without Medicaid, we don't have health care in this state. You need to understand that. Medicaid funds the hospitals, and Medicaid is funding the majority of care in rural Mississippi. And so this Medicaid is extremely important to the healthcare infrastructure of this state. It is the preferred payer for all the hospitals. You can ask them, you don't have to ask me. No deductibles, no co-pays, and they pay on time versus most other insurance plans that do have deductibles and co-pays and drag out payment as long as they can. But, the DISH program, now with the supplemental MHAP direct state payment program, that's what's keeping our rural hospitals alive, and please be aware of that. So don't just look at Medicaid as insurance for impoverished special needs individuals. It is that, and that's the most important part of Medicaid, is taking care of the least of these. But without Medicaid, nobody in this room is going to have a hospital. So we have to take care of the Medicaid program. And as a non-expansion state, there are ways that we can take better advantage of the Medicaid program, base traditional Medicaid. There are opportunities through waivers to determine what Mississippians need that Medicaid can fund, that is not Medicaid expansion. But I would beg you to fully fund Medicaid. I can tell you the Division of Medicaid is being very well run administratively, very conservatively run. We work hand in glove with the Division of Medicaid, and I have great confidence in their leadership and how they're administering the resources that you and the federal government are giving to them to take care of the health needs of Mississippians. But as a rural Mississippian who still lives in Warren County, the only way we have a hospital in Vicksburg, Mississippi is because of the Medicaid program. So, please take care of the program. Please fund it to the highest level. To me, as a good financial conservative, I don't understand the economics of not fully funding it when you have a 3-to-1 drawdown. The more we fund Medicaid, the more we draw down, the more that it flows into the health economy, and the more it flows into the economy of the state. But there are ways that we can use Medicaid as it is, based on how we fund it and based on how we use waivers to close that coverage gap. The Senate looked at interesting way, session before last, when the Senate proposal, when the Medicaid expansion debate was going on, that was not what y'all were proposing. The Senate was not proposing expansion. It was just, it was making Medicaid more robust. We are a fairly strict state when it comes to Medicaid. It is more difficult to be on the Medicaid rolls in Mississippi than the majority of states. So opportunities there outside of Medicaid expansion. Mr. Chairman, those are 4 ideas that make a lot of sense to us at the Department of Health that we are continuing to study, and I'll be happy to answer any questions.
Thank you. Let's have some questions for our state health officer. Got the expert up there. Any questions?
I did include some information about ICRA, if you've never heard of that. And I also included the state statute related to the high-risk pool for your information.
Member of the committee has a brochure from, well, Dr. Edney, thank you so much. And I
Thank you.
personally, every time we've had needs, the Senate Insurance Committee and relied on you for your knowledge. You've been so helpful to us. So we thank you very much.
Thank you, Mr. Chairman.
Thank you, Dr. Edney. Okay, our next presentation is on transparency and dental benefits from the Mississippi Dental Association. And I'd like to welcome Riker Lackey to come up and introduce our guests today. Did Riker leave town? Wani Sherman going to be here. Okay, Wani, thank you. I'm sorry.
I'm not Riker. Thank you, Mr. Chairman, for having us here today. I'm Wani Sherman. I'm the Executive Director of the Mississippi Dental Association, and we're happy to be able to talk to you today. I'd like to introduce our 151st President of the Mississippi Dental Association, Dr. Charles Belknap. He's originally from Crystal Springs, Mississippi. He graduated from Mississippi College and went to dental school at the University of Mississippi Medical Center and did his pediatric training. He is a pediatric dentist in Hattiesburg and Laurel, and he has been providing leadership for our association for many years. And so he is going to share the information with you about our transparency and dental benefits.
Thank you, Chairman, for allowing me to be able to come here today. And wanted to simply talk about a big need that we as dentists have dealing with dental insurance. There's 2 questions that often come up when we present treatment plans to patients is, after we go through what we see that they need, they ask us, does my dental insurance cover it? And oftentimes, if it doesn't cover it, they may not elect to be able to have that treatment down, which increases the cost of treatment later on and doesn't help their health. The second one is, what is the best dental insurance I can get so that I can be able to access dental benefits? And we have a hard time answering those questions. First off, who is the MDA? Mississippi Dental Association has been here for 150 years, and we are protecting and promoting oral health care for Mississippians. We represent over 800 dentists across the state and 84% of Mississippi counties, as well as almost 200 dental students and residents who are in our state. Dental insurance is different from the medical insurance. Typical dental plans have annual maximums that haven't changed since dental insurance came about. Often the annual benefit limit at $1,000. Some plans may go up to $2,000. And true insurance protects against major unexpected costs, but dental benefits are usually you have a plan and they will pay a certain percentage or a certain amount for exams, for cleanings, for preventive services, and then for some restorative procedures up to an annual maximum benefit. And we believe that patient dollars should be spent on patient care, not insurer profits or administrative costs. And Mississippians and Mississippi businesses deserve to see real value for what they pay for. The lack of transparency has led to that the dental insurance has not kept pace with the cost of inflation and for providing care. Over the last 5 years, costs for dental products and procedures has increased as well as everything else has. And premiums continue to increase, but the dental benefits have stayed the same over the last 20 or 30 years. Mississippi dentists are committed to serving patients and not insurer profits. We want to, as patients sometimes don't want to come to see the dentist, and they expect a lot from dentists to be able to make it a dental treatment accessible, and also the ease of being able to have it. And so we have to be able to provide a certain that. As small business owners, we have to be able to pay our staff, pay for the cost of materials and other things with that. And dental insurance benefits often don't be able to reimburse adequately for those procedures. And we believe that fair compensation ensures access and sustainability for care across the state, and reporting standards must be clear and consistent. We would like to support legislation requiring dental benefit transparency reporting. We want to ensure funds go directly to patient care, not excessive overhead. And other states have, I think there's 9 other states who have strictly dental loss ratio transparency language. And our bill will model our neighbor state, Louisiana, who just this past July had their first round of reporting for their dental loss ratio. So what is reported? Basically, this is a dental ratio which takes simply the amount of dollars that are spent on patient care over the amount collected from patient premiums. So basically, we compare how much money is spent for premiums and how much is delivered for dental benefits. In Louisiana, we looked at, they have individual plans and reported also for group plans. And the variations ranges from 23% all the way to 90%. So on the low end, for every dollar that went in for a premium, went for 1/4 for dental benefits. And we think that's not adequate. Some plans went up to 90%. We think that 90% for every dollar provided back in return for dental plans or for dental benefits is important for the patient. Dental caries or the dental disease is the #1 preventable disease in the nation. And we do that as oral health providers. We try to be able to educate the public about this disease, but it affects most every family and in Mississippi. So Mississippians need to be able to have true transparency so that they can be able to decide what dental insurance provides the most benefits so that they can access their oral health care. Oral health care is the gateway to overall health. Everything that we eat comes through our mouth. If our mouth is not healthy, it affects our whole body. And Mississippians are asking that we be able to provide help for them so that they can be able to choose the best companies to be able to go with them to provide their dental benefits so that they can improve their care, improve their overall health, and be able to be better Mississippians. I'd love to be able to answer any questions that you might have.
Doug, now I'll ask you the first question. What states have passed legislation to require this transparency? And do they all report to the insurance commissioner?
There are 9 states, and Ms. Wani has a list of those that's there. I think Mississippi, Virginia, Oklahoma, South Dakota, California, and there is variation in some reporting. We believe the true dental loss ratio should just be able to have dental premiums compared to what they pay for dental benefits. You can group in other things in there to be able to change that provisions, and some states have done that. And that is what we want. We want to be able to clear transparency. What dental benefits go in exchange for my dental premiums?
Senator Bryan?
You know, some people say they have a bad memory, but I've got a good memory. My memory is so good, I sometimes remember things that didn't even happen. And this may be one of those situations, but I think I recollect that the Affordable Care Act required 85% of health insurance premiums to be paid for health care, at least.
That's correct. For medical insurance, dental was not included in that, I believe.
And so I wanted to think for a minute about why, if that was feasible for health insurance generally, it wouldn't be a simple thing to just have a copycat provision for dental insurance and be done with it. Based on what you're telling us, it seems that, as you say, a lot of the dental plans are basically for routine procedures and are not for what I think we think of when we think of insurance is the really big items. Are there dental plans that do include more difficult, more expensive procedures? How did it develop that we have these different types of plans? And it seems to be getting at what a dental insurance plan actually does is sort of the heart of the issue.
You're absolutely correct.
Thank you. That's all that's.
There is no, currently as it is,
We can stop right there. It's all going to be downhill.
there's no incentive for dental insurance companies to provide dental benefits to patients because there's no reporting of that. And so this dental loss ratio will be able to show what percentage actually goes towards patient care. It may have started off as providing that $1,000 could provide 2 crowns. Crowns used to be $500 a piece. That is not the case if you've had to have a crown lately. And so there's not had anything to be able to increase over that time. We believe that if we have adequate transparency for what is going on, they will see most insurance companies, I think, provide dental benefits because they know that they can make some type of profit what they need to, because they don't have to report what they be able to pay for the dental benefits. So if we have, we can be able to see which company be able to values that and be able to provides the most patient care for that. They will be able to get more enrollees to be able to enter their products, and then other companies will have to be able to change the game to be able to go and provide more benefits to that. There's lots of different ways. Over the years, we have come to this last 2 years, tried to introduce this, and all this is going around across this nation because dental insurance has not kept up with not providing the services that people need. And there's a lot of little hoops that they can be able to go through to be able to do that. But we'd have to be able to get back to the accurate reporting to be able to actually provide patient care. Mississippi businesses need to be able to have that because the number one reason to be able to miss work is usually for dental appointments. They have to be able to take off for dental appointments. If we're able to have good dental benefits that provides better oral health, they're able to be able to stay at work better. And also the number one reason for missing school is usually for dental appointments as well. Get better oral health. More Mississippians are able to be there to learn. They're not having toothaches, and that helps all of Mississippi for years to come.
Well, again, I may be wrong about this, but my recollection is there were so-called health insurance policies that had a cap of about $1,000 a year. And I think that maybe those have sort of greatly been reduced after the Affordable Care Act passed. And of course, there was much turmoil about people losing their health insurance. Well, if the most you can get out of your health insurance is $1,000 a year, you don't have any meaningful health insurance is the way most people, I think of insurance. Why wouldn't at least one step be just to prohibit dental plans that had an annual cap of $1,000 and require an annual gap of, pick a figure, at least 5,000? What is the problem? The ability of me and everybody else to choose to go to the dentist when we want to and delay if we don't, and increased usage if I didn't have to pay to go have my teeth cleaned. I mean, it just seems to me there ought to be some more direct way to get at the problem.
Yes, it would seem to be that they would value that and want to be able to provide services for their plans, but right now they don't have to. Usually dental is added on as either afterthought to try to be able to help employers be able to gain employees. We offer dental benefits and they can do it at a cheaper plan. And so you keep costs low, you be able to get that to do it. So it drives that industry, but that would be I think this is the first step to be able to provide to see what is actually going on. And when insurance companies will see it, hopefully they can correct that themselves for true competition. Because right now there's nothing free about our free market system for dental insurance in the state. And this true transparency is needed to be able to see what is going on, to shed a light on that. And then free market forces can be able to do exactly what you're seeing. We have $2,500. $5,000 to be able to do that and be able to work it out. There's ways to be able to do it, but now there's no incentive for them to do that. And we need this transparency language in order to be able to do that. Does that
Thank you.
help?
Thank you.
Any other questions?
Just a quick question about transparency. Is this information not currently available through the Department of Insurance? These companies, I would think, have to file a stat filing that would include a medical loss ratio or a dental loss ratio. And I don't know. They're not, okay.
And to my knowledge, it's not, Mr. Jenkins.
And I think, I mean, to further what Senator Bryan was saying, I don't see these really as I think it's a bit of a misnomer to call them insurance. It's not major medical insurance. It's closer to like an Aflac type indemnity plan where if you have X happen, you get paid X, whether that goes straight to the provider or straight to the individual. So there may be some fixes around there.
Thank you.
When we talk to the dental insurance companies, they are violently opposed to MLRs, which, you know, that it's whatever the legislature wants to do. But what most of them have told us they would probably end up doing is going to what they call dental plans. And if that happens, then there's no regulatory authority at all over the insurance. Is direct consumer stuff. So it presents some real problems. It's this is not an easy question. You know, we've met with Dr. Belknap and looked at we spent some hours together trying to figure out where we need to be.
I'll say that there has been legislation introduced here that would require a certain percentage of the premium to be paid on dental procedures, and that's the medical loss ratio. And what we're talking about now is just transparency. We're trying to get the data together to report to the insurance commissioner's office to see how much of the premium is actually being spent on procedures in the dental office. So that's what we're talking about here.
We have a little of that, Mr. Chairman. We know how much premium you have, and we look at your loss ratio, so to speak. So if they take in $1 and we know if they spent 70 cents of that dollar on medical or payouts, we can tell you that today. That's basically a rate driver.
I just didn't understand. You said that the providers had told you they would switch to something other than insurance. Well, you said that the insurance companies said if there was more regulation of dental insurance, they would move to something that wasn't insurance and there would be no regulation at all.
Senator, it would be something similar to what we call a plan. It's plans are unregulated. It's like a house warranty. We don't regulate those. It's just they would sell you kind of $1,000 a year. You could get $1,000 worth of benefits.
I'm sorry. I just don't understand what you mean by a plan.
The plan is like insurance, except it's not regulated. The companies offer you certain benefits and you pay $1 or whatever you pay for them, but there's no guarantee. There's no backup as to what will be paid out. It's strictly an unregulated product. It's self-funded, basically.
Any other questions? Dr. Belknap, thank you so much for being with us today. I'm aware of model legislation going through the National Association of Insurance Commissioners that Commissioner Cheney participates in, and also National Conference of Insurance Legislators, NCOIL. And we're going to be attending a meeting, and they're going to have a model bill, hopefully that we can roll out, which has an opportunity to pass in Mississippi. We'll look at what they've done. We thank you for bringing this to our attention today.
Yeah, thank you for the time.
Thank you.
Thank you.
Thank you. Juanita Sherman. Okay, a very important part of healthcare, the process of healthcare in Mississippi certainly is our health plans. And I would like, please, to ask a familiar face to come forward, Drew Maddox, who's with the Mississippi Association of Health Plans, and he's going to discuss the rising cost of healthcare, a payer's perspective. Thank you for being with us, Drew. You have a handout, I believe.
Yes, I do.
Lauren?
I think,
them
I
here.
think you've already got it on your desk. How are y'all? Good afternoon. For those of you that do not know me, my name is Drew Maddox. I'm a principal at Cornerstone Government Affairs. I'm a contract lobbyist. In that capacity, one of my clients is the Mississippi Association of Health Plans, and I serve as the executive director of that group. If you'll take a look at our first slide here, you'll see these are our member groups. These are all of the companies that make up our board. As you can see, there are a variety of interests, in Mississippi with regards to health insurance. You'll see TrueCare on that list. They are our newest MCO here. You'll also see folks like Magnolia Health, who is also an MCO, but also pretty heavy in our marketplace as well. And then you see folks like Humana as well, that is the TPO and all of our TRICARE coverage here in the state for all of our vets. And so that's pretty much who makes up our board. Let's see if I get this right. Yeah, and so this is what we do, right? So we really have three main functions. So we facilitate communication among our members. So in addition to our board, we have a variety of pharma groups, TPAs, med tech folks, variety of folks that have an interest in the healthcare space here. We work to bring all those folks together. We also work to advocate on behalf of our board, and we'll talk about that in a little bit later in a slide we've got that talks about the bills that we work on in this building. But our board sets our agenda. We meet every 2 weeks. We have robust discussions. We try to be consensus, right? The board doesn't send me up here working on an issue just for one of the plans. We try to have pretty broad consensus on the issues that we tackle. The other thing that we do is we have events and we provide resources, and we try to communicate with everybody and really build out our ecosystem, that builds on communication and helps each other out. That is the voice, and that is kind of what we serve to do. I put this slide in here too, just because as we're talking about health insurance and insurance in general, I really like to start from a place where we define risk. And so when we talk about insurance, all we're doing is we're talking about paying your premiums in the event that something's going to happen, right? If you have car insurance, like the state mandates, right? You are paying those premiums every single month in the event that you have a car wreck, and you'll be able to pay for the damage to the vehicle, the damage to other person's property, or the damage to someone else. Health insurance functions pretty much the same way, with a little bit of nuance that we try to spread risk out in a way that's actuarially sound, in an effort to drive premiums down. By the way, stop me if y'all have questions on any of this stuff. Ooh, went back. So this next slide, so I tried to piece out something that's going on in the industry around premiums, right? As you'll see, I've got 3 different charts here, and the font's a little small, but I wanted to kind of talk with these a little bit. So the one in the top right corner, all of these are going to be representing premiums, okay? Your light blue line is going to be your family coverage premiums. Your navy blue line right there is going to be your single individual coverage premiums. As you can see, our family and group coverage is rising quite fast, and our single individual coverage is still rising. It's just not as quick. The chart on the bottom left, that is going to be your large firms and small firms. Again, the powder blue is your large firms, your small firms are navy. Those are both premiums. Again, those are steadily rising. And then the one right beside it is going to be your self-funded versus fully funded as well. Again, the powder blue is self-funded, fully funded is navy. Again, those are rising. Yes, sir, Senator Brown.
I'm not trying to be difficult, but on several occasions you've said, as you can see. No, I can't see. The charts are too small, the print is too small, the handout I have is too small to read. I don't know what the different colored lines mean. I don't know what the 3 charts mean. I see a lot of things going from the lower left to the upper right, but.
Well, then you got my point, right? Like that's the one we're trying to prove, right? Is that these are going up. I can get you printouts that are larger, or
I think this is a complaint I have about every single what do you call these things?
We can certainly get to bigger
Power-
TVs too.
PowerPoint. Yeah. It's another instrument of the devil. Anyway, but thank you.
I apologize for the font size. Other questions about the charts? Okay, on the next one, I think this one's a little bigger, so I think we'll be able to see it. This one, we try to tie it all back together, okay? So this is cumulative premiums versus inflation. Again, we break these into five-year chunks, okay? The orange is going to be the premiums. As you can see, those are going down over time with a little bit of spike in the 18 to 23, fourth quartile over there. The dark blue is earnings. Those are going to be wage earnings, right? And then the light blue is going to be what inflation does. And so I really tried to tie the three charts that Senator Bryan couldn't read. I tried to tie those in together and really hammer it home here with what premiums are doing, what earnings are doing, and what inflation is doing at the same time. You'll see, look, there's an anomaly right there in the 18 to 23. Again, you've got a spike there in the COVID. You had some COVID numbers and premium stuff happening there too. Okay, next slide. And I did print this one out on its own page, Senator Bryan, so you can take a look at that one. These are the 6 main drivers of healthcare as we see, as we see them. We did get another print. Yeah. Okay. All right. So I wanted to spend a little bit of time on this one. So this was a slide that was put together by one of our members from another presentation. So I tried to borrow it from them. But as you'll see, these are the 6 main drivers of healthcare cost right now. You'll see GLP-1s right there. That is going to be your weight loss drugs. Again, we're seeing huge spikes in people taking those for non-diabetic situations. Also, you'll see specialty medications is also a big driver. These are going to be your biosimilars. These are going to be your very, very expensive drugs that you take once a month that have special care instructions and things like that are just very, very expensive. The next driver is going to be your chronic conditions. This includes behavioral health. And so you'll see, and I hope you can read this, but you'll see that 90% of all U.S. healthcare spending is for people with chronic conditions. Again, that's going to be diabetes all the way through your mental health and behavioral health conditions as well. We also have an aging population. As you'll see, we're living longer because medicine's getting better. That's a really good thing, but it's also a costly thing. I was talking with my 8-year-old yesterday. I was telling him that I was coming to do this presentation. And I was telling him that one of the things that drives up cost is people living longer. And he said, well, I don't understand that. And I said, well, think about your great-grandmother, right? She's sick almost every week and she's in assisted living facility. And then think about yourself, right? You never go to the doctor anymore. I was just telling Dr. Chevalier that I'm in that window where my kids don't go to the doctor anymore. But it means it costs more the longer that we live, and it's harder to take care of our elderly, more costly. You'll also see cancer care is also a big driver. Again, we're getting better at treating people with cancer, but that is also pretty costly. And then also the last one is going to be healthcare labor cost. We really saw this happen after COVID, specifically around travel nurses and professions like that, where we really saw wage growth. And in a state like Mississippi, which can't keep up with those wages, it got really hard for us to recruit and maintain talent here. Questions about those 6 drivers of cost? Okay. So the next slide is some of the, Commissioner Cheney.
Thank you. And looking at your cost drivers, from some plans that we see and actual insurance, we look at pharmaceutical as being between 30 and 40% of the cost driver. If you added the GLP-1 drugs, the specialty medications, would that come up to that same number?
I can't say definitively, but I think we'd see similar trends.
Thank you.
I mean, there's all sorts of new research coming out on these GPL1s right now. And I mean, I don't want to talk about it just because I'm not a medical expert and can't get into the weeds. But again, like there's some negative long-term impacts that I think we're discovering on those GPL1s as well in non-diabetic scenarios. Dr. Bryan?
Thank you, Drew. On the previous slide, I had a question, if we could go back.
This one?
Yes.
Yes, ma'am.
And really just for my clarification.
Yes, ma'am.
Okay, so in my real life, like when I first look at the chart, I'm like, my goodness, like health premiums are going down, insurance premiums, but wages are going up and inflation's going up. But I think I just wanted to point out, and you correct me if I'm wrong, but these are in 5-year chunks. So it's kind of comparing to the previous chunk, right? Like,
Yes, ma'am.
okay. And so I think that's important that we all recognize that insurance of all types, but particularly healthcare insurance, is going up and continues to be a hardship was the point that I was, right. I know.
Yes, ma'am. Yes, ma'am.
Because when I first glanced at it, it confused me, and then I looked in the data. So probably everybody else picked up on that, but.
Yeah, I mean, I think the closer that premiums and earnings get, the worse it is for consumers.
Absolutely. Yeah, I mean, because I thought this doesn't make sense, but it does make sense when you read the fine print that the way it's chunked it's far outpacing what people are making and what inflation is.
As a percentage of your take home, yes.
And certainly this next slide is part of why too. And
Yes, ma'am.
and then also consumer inflation and medical inflation are two completely different topics as well. And medical inflation outpaces consumer inflation. So,
Yes, ma'am.
no, thank you for that. I just want to make sure I was tracking along. I appreciate
Yes, ma'am. Sorry for the confusion.
No, it's me personally, and I appreciate it. Thank you.
Okay, I want to jump ahead to the issues that we work on up here. So I pulled out a few just to talk about. So the first one that I wanted to talk about, I think is a real success story. So prior authorization. So in 2022, there was a big push for gold carding here. That bill passed. Ooh, yes, passed and was vetoed. The governor then came back and asked the industry to work really hard on bringing a bill back up here that we could support. We did. We worked in conjunction with providers and the governor's office and legislative leaders, and we came back up here and passed a bill that is one of the model bills in the country. Senator Michelle, you go to NCOIL, you know how proud of that bill they are. I just was at AHIP 2 weeks ago. Again, while they won't say that they're supportive of it, I will say that our sister states, organizations similar to ours in different states, all look to our bill as the model and are begging to have something similar. I will say that we are still in the implementation phase of that reform. We've been working closely with Commissioner Cheney's office on that, working on the portal and different things like that. And so, again, not to say that these things don't lead to be revisited from time to time, but I will say that I think the industry as a whole, and that's provider and payor, did a really good job of getting something done there. Next, I want to talk about PBM reform and legislation. This is one we've worked on for quite some time. It's a hot topic up here. Again, I think that the association's perspective on this is we believe that transparency and oversight is always a good thing. We believe that should swing both ways. But certainly, we're not ever going to stand in the way of transparency and oversight. I will say that our line in the sand is on pricing. We don't believe that the government should set a price, should insert itself in any sort of pricing. We also believe that we shouldn't insert the government in between two contracting parties. So if a large employer has a preferred pharmacist that they want to use and send their employees to because that's the best deal for them, we ought to let them do it, and the government shouldn't tell them no. But we remain ready to work on that legislation again. We've met with pharmacists, we've met with providers, we've met with the department, we've met with everybody that will meet with us. But again, our line in the sand is on pricing. Reimbursement requirements. So this was something that bubbled up last year, and this is one I want to talk about a little bit with regards to mandates. So every time we mandate something in the code that insurance, whether it's public or private pay, That makes costs go up. And as those costs, on the public side, if it's in Medicaid, that makes, the appropriation go up. But if we push it down on the private side, that makes premiums go up. We encourage the DME folks to work with the plans, to work with each one. If they've got a problem with one, come see us, talk with us. Let's work it through. But we certainly don't want to legislate or mandate any payments for DME. White bagging was something that we worked on last year as well. We had two main concerns with the bagging bills. That was around patient safety, which I believe this bill addressed. And then we also had a concern around the hospital. We didn't want the hospital to require that we pay over and above a negotiated rate for a pharmaceutical. We believe those protections were in that white bagging bill. We would have liked for them to be a little stronger, but they were there. The last one I want to talk to you all a little bit about is the emergency transport legislation. This is something that we'll be back working on again this year. Again, we've got a really interesting scenario where we've got an upside down billing rate in the code, where it says that the insurer will pay 325% of the Medicare rate or the greater of bill charges. We've not found anywhere else in code where it says greater than. And again, that just opens up for unmitigated cost to be passed on to the plans where they may not be necessary. And so again, we're going to come back and try to work on that legislation again. The three things that we're asking for there, we got to flip the rate. We want to insert some transparency on the local contract. So if an ambulance provider has a contract with a local county, that's a great thing. We just need to know what it is so we can encompass it in our rate as well. The third thing is on the treat and triage. We'd like to insert a telemedicine visit there as well. If you don't need a bus on the scene, let's not send one. Those are expensive. If we can have telemedicine work in that scenario, let's let it work. Questions on the things that we've worked on or are planning to work on? Commissioner Cheney.
Thank you, Mr. Maddox. On the ground transportation issue, we provided to the proper committees a cost of the bill charges that we accumulated from most of the carriers in 2024 versus what was actually paid out. And the difference, which we quantified on spreadsheets, was well over $100 million. And that goes to the increase in premiums on healthcare. Do y'all have a proposal that would either repeal the bill or to require the counties to set a minimum above it? So the issue becomes one of mandates. And once you open the door of mandating, you kill networks and rates will go out of sight.
So we will have a bill this session. Look, I mean, if you're asking me if we should just repeal the whole code and force everybody in network, yeah, I think we ought to do that. But again, that may be the shot too far, right? Again, these relationships work best when you're in network. Let's work to get everybody in network rather than have folks out of network.
Well, let me give you an example of why we're concerned about it at the department. We had unfortunately, Baptist System sent us a reimbursement rate for ambulance move out of Memphis. Thank God it didn't get into Mississippi, but they charged a lady to move her 3.9 miles over $4,000. And she had a wheelchair, she was knee operation or something. You could have got an Uber for $14 or $20. We finally kicked that back to the Department of Insurance in Tennessee and let them worry about it. But that's the issue that we face. And we also have several carriers that have told us that the lawsuits have started and
yes, sir. That's happening.
okay. Just hope you have a solution.
I hope so too.
Dr. Bryan?
Drew, thank you for that.
Yes,
A comment about the expense of the bus. I totally agree. They're expensive buses and some plans have them and some don't. But food for thought, as we move into more and more value-based care, where this came from, I'm a huge proponent of telemedicine. Like we need it now, we need it yesterday. It's amazing. But we've got care gaps, right? So we've got mobile mammograms that can be done. We've got diabetic screenings that can be done. We've got, diabetic foot exams that you and I both know matter when it looks like their risk score, and that's important to the plans too, and all of that. So I think that's part of working with the medical community on when we've got folks that want to go to underserved areas. We need some infrastructure in which to help, because once you tell somebody their sugar is 500 and you've made it easier, there's no doctor within 60 miles, but you've just figured out that they're really sick, they're more motivated to engage with telemedicine. So I don't think a fleet of buses is the fix, but I do think using servitude and willingness to go and figure out from those who are reticent to go or to use their benefits can help us with the value-based care. So you're totally right about telemedicine, but there's still some value in that on the ground, touching the human and screening.
Yes, ma'am. And some of our plans are doing this already and doing a really good job of it. And you'll see them out in the communities. But we need more. You're absolutely right.
Follow up, sorry. And yeah, and to the point, I think the point of the conversation at this level has been that there are many physicians who want to be a part of that just because it is the right thing to do. And so some plans are doing it well and want, I mean, I have heard only positivity from the plans about it. So I think I just wanted to say that a fleet of buses is not the fix either. It's all of the things that you've talked about, and telemedicine's huge. So
Yes, ma'am.
thank you.
Senator Bryan.
I'll put to one side my response to this concern about the government interfering in contracts, but I'd like to mention a dilemma, and I'm not trying to pick at anybody, but I want to describe a dilemma. There is this reference under the white bagging bill, which says this bill restricts insurers' ability to direct healthcare delivery. I'm not sure we all understand the implication of this notion that insurers are directing healthcare delivery, but they are, and they have been for some time. And the insurers who are directing healthcare delivery, generally speaking, are motivated by profit. That's not a bad thing, of course, but the profit for the insurance company may not coincide with what we want for public policy reasons. And I think the dilemma is, what do we do in terms of public policy in a world where a lot of decisions are being determined by insurance companies? I'll give you an example. I see Aetna's name right here, and I remember Aetna. They sent out postcards to all the employees of the city of Amory. Aetna had the health insurance for the city of Amory, and they sent postcards saying, don't go to the hospital if you've got this problem. You need to go to a ambulatory surgical facility where you can get this done quicker and it'll save time. Well, of course, there are no ambulatory surgical facilities in Amory. So even assuming one wished to go to that, I'm sure Mr. Aetna spent a lot of time calculating the distance and the time and expense of going to the ambulatory surgical facility and the distance that it was from Amory and on and on and on. But this is an example of things we do, including in driver's license offices and all. We're shifting the burden and the expense to an individual, particularly individuals in rural areas who have to get transportation to some place. And that doesn't count as a cost, but it's a real world cost. But the more troubling thing is that one of the things that's happened to rural hospitals over the years is that services that used to be performed in the hospital are no longer performed there. And the way that a hospital, generally speaking, 30, 40 years ago, kept going is that it had a mix of procedures which some paid more and some paid less, but you put it all together and you had enough money to run your hospital with. And you had a pretty good payer mix, generally speaking. And so as time goes by, things which used to be done in hospitals no longer are. That reduces the volume at the hospital, reduces the critical mass. It makes it difficult for a hospital to stay open. It's also the case that a number of for-profit entities are starting up, and they're not starting up for the purpose of treating those who have no ability to pay. The people with no ability to pay still go to the public hospital. But we have removed from the public hospital the payment stream of those who did have a ability to pay, and we're in a position of a downward spiral or a death spiral, if that's an interesting term to use, for a number of hospitals. There's a similar problem with reimbursement for pharmacies. I believe it is a matter of public policy. There's a public need for hospitals in rural areas. I believe that as a matter of public policy, we'd like to have drugstores in rural areas. And so the dilemma that I think we face as policymakers is, what should we do? What do we do in a world in which healthcare decisions are being made by entities who don't have this broad perspective? They're interested in controlling cost, and whatever healthcare is there, they have an obligation to make sure they have a comprehensive network, but that doesn't necessarily mean more hospitals and more pharmacists. And I just think that we're in a dilemma where we're giving people incentives to do X, and we would like to have not X occur. And I don't know what we're supposed to do about that. What do you think we should do about that?
I don't know.
You're in good company.
Brian again.
So just insight for that. As far as the health plans go, they generally are following a lot of times what Medicare is doing. And again, more questions, I don't have an answer, but for insight into my family practice, the same mammogram I order at the hospital is, say, $1,000 more. I'm throwing that number out there. I could be off based on the facility fee. And then they can get it at a community-owned center for a lot cheaper. And within the Medicare program, with the federal dollars, the more we save in a value-based program, the better we do financially. There's two different models. See as many as you can, as fast as you can, or take real good care of them and make sure you screen them and that they don't have cancer and you treat their diabetes well and so on. And there's a shared savings program federally where those dollars trickle down. And so there is an onus to look for the best deal for Medicare. And that's coming from Washington on how we push our patients. And so to stand up a little for the plans, yes, it is for profit, but also they're following along what the federal government is doing too. And we are best practices always advised to avoid the ER, to do outpatient when you can, to schedule tests, not inside the hospital when you don't have to. And the end result is exactly what you just said, especially for small communities. So it's way above my head, but I can see the big picture you're talking about, and it goes beyond the plans. And I don't know the answer, but it is happening.
Well, again, I'm not beating up on the plans. I'm not trying to do that. I'm just trying to say they have incentives to behave in a certain way. We shouldn't be surprised to see that they behave in that way. Do we as policymakers want to come up with some different incentives, or do we just basically want rural Mississippi to shut down and go away, because it seems to me that the policies this legislature is pursuing and is planning to pursue in the future are making life worse and worse and worse for rural Mississippi. And when I say rural Mississippi, I'm talking about 70 counties.
You've got another page. You want to go to it now?
Yeah, look, one last page, guys.
Glad to have some more questions.
And look, this will be a little bit of a rehash from what Dr. Edney said. So look, I'm so glad that he mentioned the ICRA stuff. These are a no-brainer. We should absolutely do this. Again, we'll be asking you guys to pass a bill on this this year. Again, I've got two members that are very interested in that, Oscar and Magnolia. But again, we'd have a lot more interest in that if we had a bill. Health benefit plans. I want to talk a little bit about this. So this is something interesting that y'all did 2 or 3 years ago. Y'all allowed the Mississippi Farm Bureau Federation, Senator Michelle, you sponsored the bill, Mississippi Farm Bureau Federation, to create their own health benefit plan. They're going to start selling plans November 1st. This is going to change healthcare in rural Mississippi. It really is. We got to be careful about how we talk about these things, because it's not health insurance. This is one of, similar to what Commissioner Cheney was talking about with dental benefit plans. But again, they will have limits. You can be denied coverage. You can, if maternity is going to be a rider in these plans. So again, they're really kind of member driven and is really going to drive premiums down. So we're really excited about that. Another similar example is the Mississippi Bankers Association has a MEWA, and please goodness, don't ask me to tell you what those letters mean, because I don't know. But it's very similar to a health benefit plan. The last thing that I wanted to mention was Marketplace. I would love it if we had a state exchange. Our members would love it if we had a state exchange. We have several members that are very, very active on the federal exchange here. Again, there's some uncertainty with what's going on with the enhanced tax credits there. But again, for individual coverage, the Marketplace is where you need to be. Questions, concerns?
Aaron?
There we go. Just not really a question, but just to follow up on some of the discussion and to hit on a couple of things. I'll refer back to the eye chart, Senator Bryan from earlier. That graph and maybe blame the Kaiser Family Foundation for trying to put too much information. I mean, showing 25 years of insurance premiums, and if you do the math there, insurance premiums have gone up roughly 400% in the last 25 years. And, a lot of people love to point fingers at the insurance industry and point to greed and other things. If you think of the healthcare system as a car, the insurance portion of that is the dashboard. It's telling you how fast you're going. It's not what's causing the car to speed up or slow down. And that car, unfortunately, doesn't slow down. It just keeps going faster and faster and faster. And what's scary is about that graph is that it stops in 2023. And you'll see a pretty sharp spike happening in 23. And then if you refer to the inflation graph, where inflation was outpacing health insurance costs, I think we're just seeing, people are getting their renewal notices right now, and they're seeing the impact of inflation on health insurance, among other things that are going on. Anybody that has gotten a renewal notice and opened it and read it has probably seen, I don't care if it's commercial, Marketplace, anything, they've probably seen a pretty significant increase. I'm pretty scared that is going to continue. So I think part of the point on the legislation and all these things, I mean, transparency, openness, let's have these conversations, let's talk about it. But health insurance is just one facet. We'll pay for whatever we need to. We'll pay for people's gas. We'll pay for their meals. We'll pay for lodging. but all of that has to be reflected in rates. In order for rates to be actuarially sound, all healthcare costs has to be incorporated in that. And we're reaching a breaking point in this country where even your average or well-to-do or upper middle class are going to really struggle to pay for insurance. In Mississippi, the average cost or the average income for a family of four is somewhere around $60,000. The cost of a insurance plan for unsubsidized and everything is pushing $30,000. I don't know many Mississippians making $60,000 who can afford to pay 50% of that. And so we're reaching a pretty critical time. And to your point about rural healthcare, it's hitting there the hardest, and it's hitting there now. And so if we talk about solutions, the first solution is going to be get everybody around the table: insurers, doctors, hospitals, pharmacies, pharmaceutical companies. And we've got to come up with some solutions because otherwise we're all going to be left out in the cold. And the real victim will be the patient, the Mississippian. So that's just my 2 cents to wrap up, I guess, what Drew said.
Thank you, Aaron. Vice Chair.
Drew, we're the most unhealthy state in the country. Do any of your insurers discuss preventable measures for in
Yes, sir.
lowering
All,
costs and-
yes, sir. All of our plans have preventative medicine programs. They've got wellness programs. They've got most of them have behavioral health programs too that are that cover kind of your maintenance behavioral health visits as well.
and there are incentives built in?
Yes, sir. I mean, some of those are free, right? Like some of those are free things. Again, we've got a literacy problem, like a health literacy problem. Making sure that people know those things are available, making sure that they know that they're free. That's the challenge, is getting the message out there.
So if we were somehow moved from 50th to 24th, you can see premiums going down because we became a healthier state?
I'm not an actuary. But listen, the things that go in there that we can control, yeah, like those would stay flat.
And just a comment, you can weigh in if you'd like. As Senator Bryan was talking about, we have facilities that only see paying patients, and then we have hospitals that have to take everybody, mandated. If there was a way that we could maybe charge a higher licensing fee for companies that don't take indigent care or customers that can't pay, and spread that wealth among the hospitals that have to receive everybody. I mean, we need to figure out some way to level this playing field.
Yes, sir. I look forward to working with you on that. We tried to solve the access problem with you, several years. So, again, it's still there. And I think with better access come, better health.
Dr. Chevalier?
Yeah. To Senator Bryan's point, yes, the rural attack is real. I also think, though, that for the small business of medicine, so those clinics that are still self-owned and self-run and those things, there's a real attack there in the capital and anywhere else, not just rurally. Because as costs to run those facilities increase, like Drew pointed out, labor is a big cost. The cost of buying as a pediatrician, the vaccines that I need to have in the clinic and those kind of things to have readily available are going through the roof, yet the reimbursement for those things are not. So I think we also, from an access standpoint, are at a precipice where we are going to potentially lose a lot of our primary care, especially self-run in this state, in a state that really can't afford to, because you're going to have a point that no one can afford to own themselves and run themselves anymore. You're going to see every entity is going to be owned by a hospital or by a large venture capital or by some kind of super group that can do it. So I think when we're addressing these things, it needs to be looked at on the whole, and the fact that primary care is where you're going to change the preventative stats, where you're going to get from 50 to 25 If that's no longer available or it's not available in the way where patient care is number one, then we're never going to achieve that. And Dr. Belknap back here talking about transparency, that's something we've been going for in the medical world too. I think that to me, it seems like the most common sense thing on the planet that, you know, what your insurer pays for this, that it's published, what your reimbursement for this is going to be, what it costs the patient. To have to play the mystery game and file these things and wait to see whether you even get your cost back is a little nuts to me, but it's not an answer. I think the answer is massive and multifactorial, and it's going to take, like you said, everybody getting around the table. But I do think, you know, our big problem is potentially unfixable if we can't preserve primary care in the state and expand it into rural areas and have those access there. So.
Mr. Cheney.
Well, I'm a little hesitant to say this, but if the tax credits are not renewed in Washington, which I don't think they will be, we're probably going to have 200,000 more people dumped into the uninsured market, maybe more, because of the cuts in Medicaid. And that trickle down effect is there's less, these people will go to uncompensated care at the emergency rooms. And it presents a whole host of problems for healthcare in the state. I don't have an answer for it. We're trying to work with CMS to see if there's some things we could do through the high risk pool. But we've got some problems that we need to address them. And I don't have an answer for them, but we need to realize that if this happens, you're going to have more and more hospitals that are probably going to close. And if you don't have PBM reform, you're going to have a lot of independent pharmacies that are going to close. And that's probably the next topic that's coming up.
Okay, Drew, we thank you. Anything else you'd like to say?
No, thank y'all.
Thank you for an excellent presentation. Thank you so much. I want to elaborate a little bit on something Drew said, but Dr. Edney started off with about how important Medicaid is in Mississippi for our rural areas. I've reached out to the Department of Medicaid to present to us at our next meeting. And also of importance is the fact that Drew brought to our attention the GLP-1 drugs are number one factor in expected increases of costs in 2026. Our state health plan does not allow anti-obesity drugs for weight loss. They do allow it for heart disease, diabetes, sleep apnea, and just recently, fatty liver disease. Is there anything else, Patrick? Patrick's runs the program, but Medicaid does. So we're going to find out. It's amazing that from what I have heard, the very small percentage of people who have taken advantage of weight loss, getting weight loss drugs through Medicaid. And we're going to have an expert here next month on that to find out the statistics from that. All right. Our last speaker for today.
Mr. Chair?
Yes.
Those ailments that you mentioned, I thought this medical marijuana was going to solve all those problems. Are you seeing the reduction in those medical problems with this medical marijuana?
I have to rely on one of my medical doctors that's on the committee and be glad for them to answer that question. My population's a little young for it. I'm sure some of them enjoy it anyway. Yeah. Okay. All right. And our last presentation today is Commissioner Mike Cheney is lined up for us as a member of the committee. Would you please introduce our next speaker, Mr. Cheney?
Thank you, Mr. Chairman. Our next speaker is Michael Jones, who's a pharmacist in Vicksburg, Mississippi. He's one of the 2 independent pharmacists left in the city. And he's very knowledgeable of some of the problems he faces as an independent pharmacy.
Thank you, sir. I appreciate the opportunity to be here today. Thank you for the invitation. Thank you for the committee members for allowing me to speak for a few minutes. The good thing and the bad thing about going last is a lot of the stuff's already been said, so I may skip over some of mine, and then also I can maybe shed some light on some of the other things that were said. I may just invite Senator Bryan to come back up and say what he said, and I can go back and sit down because he covered a lot of things about independent pharmacy that are true, certainly in the rural areas. As Commissioner Cheney said, my name is Michael Jones. I'm from Vicksburg. I own Helping Hand Family Pharmacy. have for 23 years. I'm one of the last two that are left in Vicksburg. 5 years ago, we had 5, technically 6 if you want to count Durst because Joe had 2 locations. So now we're down to 2 in 5 years. And People's Drugstore was one of the original pharmacies in the state, and they closed in December of last year. So that's the third one in less than a year that's closed in Mississippi. There was one in Columbus. There's one. Fayette Discount Drugs just closed last week. So the people in Fayette, Mississippi now have to go 30 miles to get their medicine, just one way to get their medication. And so if you go north of Vicksburg, probably all the way to maybe Hollandale, and then south of Vicksburg, all the way down to Fayette, there's maybe 5 pharmacies in that stretch of people, in that stretch of highway for those people to be serviced with. So again, pharmacy desert is a real thing, and it's becoming more and more that way. And obviously, pharmacy benefit manager reform is something that's been a hot topic in the legislature over the past several years. Last year, we got really close to the finish line with just some meaningful legislation that would have got our foot in the door, and unfortunately, we didn't get through. I do appreciate the Senate for pushing theirs across, overwhelming support there. And again, we're going to try again in 2026 to get that ball rolling. But just to give you a few more things, Mr. Maddox also stole some of my thunder by his line in the sand. I told my wife the same thing last year when I saw some of this coming, that I also drew my line in the sand. And the simple fact is independent pharmacies cannot fill medications for less than what the cost of goods is. So if I pay $10 for it and I have to sell it for $8, not going to be around a whole lot longer. So you have to make that decision, unfortunately. And again, the patients are the ones that suffer with that because they have to be either sent somewhere else or they may go without their medication. We give them the opportunity to go and find the medication for them in another store and transfer it there for them. But the simple fact is a business of any sort cannot operate in a deficit. And so we're the same way. And it's sad to see that healthcare has come to the fact that the insurance companies are telling us all what we can do. Obviously, the dental world seems to be facing the same fact we are. I wasn't aware of that. And again, just as Senator Hobb Bryan said, the rural part of Mississippi, which is the majority of Mississippi, can't do without the health care that we provide or the hospitals provide in that vein. So just a quick number just for us to say, $12 per prescription is what it costs for us to get it out the door. And so when your PBMs put in the extra fees, the reimbursement, less reimbursement, your margin goes to shrink. And so a couple of the fees that they put in on us that were illegal a few years ago, what were called clawbacks. And so now the clawbacks have moved to something called transaction fees, which basically is like a credit card fee, so to speak, for them, cost of doing business with the PBM. And also they have something called an effective rate adjustment, where basically they may come back and say, today they pay, again, we'll use the number $10 for prescription. And then they go back and say, well, on October 29th of 2025, according to this formula that we were using that day, it was really only $8. So we're going to get that $2 back in the effective rate. It's hard to make sure that you're getting the correct amount filled on a prescription when you're not 100% sure what that is. So let me give you the real world example of that in my store. From January 1 to the end of September this year, I'm looking at $77,000 in effective rate and transaction fees across the board. So that's $8,500 a month. By the end of December, that's going to be over $100,000 a year for my store. So you take that through the 300 plus independent pharmacies in the state, you're looking at almost $35 million that are taken away by the PBMs just for that. I'm not counting the under reimbursements, and I'm not counting, the other things that they pay or don't pay. And that's a lot of money that's not going into the counties and the cities and to the government areas there. Also, you can assume, well, my store may be above average, and we can assume that's the case, but if you cut that in half, you're still looking at $18 million of lost revenue, either by the pharmacies or the tax base in that area. From a policy perspective, you've seen a couple of states around us pass laws that have incorporated a dispensing fee, which is basically equal to their Medicaid dispensing fee for the state. Like ours is $11.69, like Alabama's is $10.64 a claim, plus their average acquisition cost. So basically the PBMs now in Alabama cannot pay their independent pharmacies or pharmacies as a whole less than that rate that Medicaid sets for them. Same rate as that. And that went into effect October 1 of this year in Alabama as a law. So we don't really know how that's going. We'll hopefully by the end of December, they'll have some numbers that we can actually compare and maybe we can use here in Mississippi next year when it comes to our legislators. So rather than continue talking about some of the things that have already been said, I did give you guys a handout that has a lot of the information on there. If any questions may arise from that. Commissioner Cheney does have my phone number. I'd be glad to talk to anybody about it. Unfortunately, number 5 didn't come out like I wanted to. I had some little check marks that were going to come along on it, but anyway, it didn't print out like I like to. So again, the PBMs do play a major role in the prescription drug supply chain, negotiating the drug prices, handling claims, managing networks. And states, including every state around Mississippi, passed some type of PBM form through their legislature last year. We're the only ones that didn't get anything to the finish line. So, you know, whether it would just be to transparency has been kind of the key word here today, stop the spread pricing, protect pharmacies. Again, pharmacies, dispensing fees and reimbursement levels do matter. I estimated $10 to $12 to dispense a prescription. Anytime you take a reduced fee, a retroactive deduction, under reimbursement reduces our viability. The clawback style practices with the transaction fees and effective rates do represent a real threat because again, we've seen 3 pharmacies that I know of since December 31st of 2024 close their doors for good. Legislation in Mississippi can help level the playing field, ensure independent pharmacies don't collapse and protect their patient access. However, full reform is still a work in progress, as we have seen. Monitoring whether the PBMs do comply, how the audit and fees evolve, and whether or not dispensing fees reflect the real cost is the key. Again, with any legislation, there's got to be enforcement from somewhere, whether it be the legislature or the Board of Pharmacy. Some regulatory agency is going to have to also be on the back end of that to make sure what's being done is what's being said is being done. So for all the stakeholders in the game, the pharmacists, the payers, the policymakers, especially the patients, the goal should be a system where pharmacies are fairly reimbursed by the drug ingredient and a professional or operational dispensing fee. And PBM profits are transparent and not hidden behind the spread pricing or after the fact deductions. And as an independent pharmacist, I can say, you know, we don't have the means to pay lobbyists like the PBM guys do, like Centene or any of those guys who are paying $500,000 for a lobbyist to come in here and tell stories that may or may not be true. The way I like to look at it is as somebody on the front line of it every day. Independent pharmacies know what we're facing and we see it every day. We see what's being taken from us and we see how it's being taken from us. And we know that unfortunately, there's not a whole lot we can do about it without the help of the legislature, somebody helping intervene, at least to stop the bleeding until we can get some meaningful reform passed in that time frame. Because, you know, nobody in Mississippi wants to see healthcare continue to spiral down like it is. Because again, we are the most unhealthy state in the nation. And without the ability for these people, and especially in rural areas, especially where we are in Vicksburg, as going at the bottom of the Delta, if you ride back from Vicksburg up 61 North, you obviously see what I'm talking about. There's just not a lot there. And for us to continue to be able to operate and be viable in these areas where we are needed, we could certainly use some assistance and hopefully, again, this year we can get something past the finish line, at least get the ball rolling for better change for us. Thank you for your time. I'll answer anything that may need to be answered, or I know PBM reform, again, is a hot topic, so a lot of questions were already given last year, but anything I can do, I'll be glad to answer right now, or if anybody wants to call and talk later, we can.
Appreciate your presentation. Thank you so much.
All right. Thank you.
We've had multiple PBM presentations. Thank you.
All right. Thank you.
All right. That's going to bring us to the end of today's meeting. And I want to kind of recap. This is our 4th meeting. We've had 18 presentations. And I want to reiterate that I'm extending invitation for anyone who has a subject that they would like to bring before us to do so. We have 2 people lined up for our next meeting, which will be November the 20th. I mentioned Medicaid. I've reached out to Blue Cross. Blue Cross is one of the largest providers of health insurance in Mississippi, and they said they'd get back to me. So we may hear from them, or we may not. I hope we do, because they certainly have a large piece of the pie in Mississippi. We may have one last wrap-up meeting early in December to see what legislation may result from this committee. Think that's the end of it, unless anyone has anything else for good of the committee. We stand adjourned. Thank you. Good.
Nice to meet you, sir.